Hi, everybody. As I said in an email um, earlier this week, we are going to highlight and review what FTAG 329 talks about. So I posted several different things this week. I posted actually, if you go into CMS, and CMS on their website doesn't make it the simplest to find the direct information. But if you go into CMS, there's a very large table, which I did post that table for you. And that table actually highlights, you know, what surveyors should be evaluating, what consultants should be evaluating of, whether or not care is appropriate. And so when we talk about FTAG 329, we talk about unnecessary medications. And so what we hope to do with this talk is we're going to talk about I want you to look at that case that I posted while you listen to this talk, and I want you to go back to those tables and think about how does FTAG 329 and where does it apply to that case, because the key thing we're going to do next week in group discussion is highlight where there are issues about unnecessary medications in that case. And so we're not going to directly talk about the case in this taped lecture, but we will be talking about the case in reference to FTAG 329 next Tuesday. So the key thing is we need to recognize therapy that may be classified as unnecessary, and what does that actually mean. We also want to highlight the regulations for the use of psychoactive medications in long-term care, and you want to also be able to be, astute to identifying that if a geriatric syndrome is occurring, where there is functional problems, that we want to be, as a consultant pharmacist, evaluating, is it drug related? So here's some key components of what FTAG 329 says. It says that each resident's medication regimen must be free from unnecessary medications. And what exactly is an unnecessary medication? And think about, when you read this regulation, it's what we teach you in pharmacy. When we talked about the other week on drug regimen review, we talked about thinking about those key 10 questions that I mentioned in the medication appropriate index. Is there an adequate indication? Is there the right dose, the right duration, free of drug disease interactions, free of drug interactions? So here's what the ruling says according to CMS. In excessive doses include duplicate therapy. So how do we identify that? Well, one, hopefully, as you become more savvy in your clinical skills, you can recognize this just by the naked eye. But the key thing is that when you're first starting out, take those medications, put them into a lexicon drug interaction, and identify that. The other thing is that you use something like lexicon clinical pharmacology, micromedics. There's usually a geriatric section that will tell you what should be the recommended geriatric doses. Think about excessive duration. So, if it's antibiotic treatment, how long should we be treating that? If it's for, like, say, acute GERD, how long should we be treating? First time depression. And then the other key thing is adequate monitoring. Are we getting lab values? Are we evaluating vitals when necessary? Does everything have an active indication? And in the presence of adverse consequences, which indicate the dose should be reduced or discontinued, is that being done? And so basically you want to apply good pharmaceutical care. And if you apply good pharmaceutical care on every drug regimen review, unnecessary med regulation should be an easy regulation to be able to follow. A key thing that's always been part of the FTAGs, actually since the late 80s and early 90s, is the use of appropriate psychoactive medications. And just recently, in the last year or two, there's been a little bit of modification, or more, maybe not as a modification, a clarification of this. And so basically, there's a big focus on antipsychotics, and so what you need to do is when you review a resident that's on an antipsychotic, the residents who have not used antipsychotic drugs are not given these drugs unless antipsychotic drug therapy is necessary to treat a specific condition as diagnosed. And so, for example, A lot of times antipsychotics get used in deep dementia and behavioral, and next semester you're going to talk a lot about dementia in special populations. But the reason why it's such a big concern is there's a lot of side effects that go along with antipsychotics. Your traditional antipsychotics like haloperidol have been known to cause extrapyramidal symptoms, where your current modern antipsychotics like risperidone, Zyprexa, olanzapine have been known to cause possible problems in glucose intolerance, increase in lipid panel, increased risk relationship to stroke, increased weight gain. And so, if a resident has to go on these, there's always that term: does the benefit outweigh the risk, and does the risk outweigh the benefit? And so, one of the rules of thumb of do I use an antipsychotic in a patient with dementia, you have to ask yourself: are they a harm to themselves, or are they a harm to anybody else? And that can be things such as physical harm, like biting, kicking, screaming. That could be mental harm to themselves, that maybe they constantly just scream out all the time. We had a resident one time that all he did was go, hey, hey, hey. And when he did that, he didn't want to focus on anything. He didn't want to eat. He didn't want to, engage with anybody. And so it was warranted a temporary trial on an antipsychotic. There also is time where people have fixations and paranoias. We had one resident who just constantly picked at his skin, and as he picked at his skin, he eventually developed sores that could lead to infection. We had another resident at one time who thought about that her daughter was still 8 years old, even though her daughter was 40 some years old. And every morning, every day, at 3 o'clock, she would try to escape the building because she thought that she needed to go pick up her daughter at the bus stop. And so this delusion became a possible harm. Now, the other key thing is a lot of times when these drugs do get used, it may be only a temporary behavior, and constantly we should be trying to review if a gradual dose reduction can be done if there's non pharmacological behavioral interventions that can be done to make sure that those are, done before we use the medication. And if we are picking an antipsychotic, we want to pick one that has a side effect profile that's appropriate for that resident. And so, like for example, of a non-pharmacological intervention, we used to have a resident who would get very agitated, and she would, if you went near her in her wheelchair. But the best thing that would calm her is they would actually start trying to get her to sing a simple song, like he's got the whole world around his hands. And when she'd start singing, she'd calm down. So you want to be able to make sure that, and you just as a consultant can't do this alone. This working with nursing, care planning, training all nurses and staff of what are those behavioral interventions and how can we modify that to improve the resident's care. The other thing too is diagnosis alone may not warrant treatment with the medication, so you want to make sure is the diagnosis, is the problem severe enough that the medication, once again, you always ask yourself, does the benefit outweigh the risk? The other one is to make sure that if a PRN med is being used, that it has an appropriate indication. It's known when to use it. There's a specific indication for use. And so a PRN medication you can't have an order that just says take one tablet 3 times a day as directed. There has to be a specific indication. If you have 2 pain meds, if you have 2, like it says, take 1 or 2 tablets as needed for pain, you can't have that as an order in a nursing home. It has to say take 1 tablet as needed for moderate pain and take 2 tablets as needed for severe pain. The other thing that can be problematic in unnecessary medication review is orders from multiple prescribers can increase the chances of receiving an unnecessary med. And so all these guidelines generally emphasize and focus on the older adult resident, the geriatric resident. And so that's why I did post the new Beers criteria. I posted the table that is given by CMS to surveyors as a guidance of what type of medications we should look at. And, some of these requirements may need to be applied to residents of all ages. So there's lots of opportunities or circumstances that warrant the evaluation of a medication's indication. Anytime we have an admission or readmission, we should always evaluate the need for that medication. One of the pearls that I like to do when I get a resident who's just been back from the hospital is to get that discharge summary. That discharge summary from the hospital will tell you why they were there, what occurred during that time, and you want to do a med rec of what were they on prior to going to the hospital and leaving after. And even though there's been a big emphasis on hospitals doing med rec, it's not perfect. If a patient's being followed by maybe two specialists, like an endocrinologist and a cardiologist, and they have their PCP, are they reading each other's orders and are aware of what each other is taking? New medications that are added on in emergency situations. A lot of times medications are added on the weekend via the telephone, stat orders. It's the late time nursing staff and the residents acting up at 7 o'clock at night or 8 o'clock at night, and they call the physician and they just say, okay, give them a benzodiazepine or antipsychotic till I see them. You want to make sure that psychiatry or somebody with a psychiatric background is evaluating residents with distress behavior. And then another key thing is when there's a change in condition or decline in function or a new symptom occur, we as the pharmacist want to rule out that it's not medication related. So considerations to include is, when do we, do a good evaluation and assessment? That's every time we review the chart. When we see that in the progress notes or the nurse's notes, that's kind of where we find out about this stuff. If there's any causes of symptoms, have we ruled out they're not medication related? If there are signs and symptoms are persistent, is there an appropriate medication that might alleviate those symptoms? Did they approach non-pharmacological interventions were considered? And a particular medication is indicated to manage that symptom or condition. Once again, when we're reviewing a medication regimen, we want to look at, does the medication benefit outweigh the potential risks? Are there target goals? That's why we teach you care planning is, what is the target goal for this medication? Does the resident have any history of adverse drug reactions or allergic reactions, and have those been addressed? And what is the history of them being on these medications prior? So, if you haven't already while we're talking, review that long-term case. Take those tables that I gave you. Take the tables that are in the new Beers criteria that I posted. There's also a new article focusing on alternative medications to consider in certain disease states. So please do, if you haven't already focused on that, I'll be sending out a reminder. That is the key thing that I want you to take away from this lecture is use that case, and I want you to be able to identify unnecessary medications, why are they unnecessary, and I want you to take an attempt of what are some alternative recommendations that you would do. Unnecessary med monitoring. So another key thing that is referenced in those tables is that is appropriate monitoring occurring. So what is the purpose of monitoring? So the purpose of monitoring a medication is to see is the medication meeting its goal efficacious wise, and also is any possible side effects occurring. Sometimes the facility may establish protocols for appropriate monitoring, and like I said, so for example, somebody's on a diuretic, whether it's hydrochlorothiazide or furosemide. You want to find out what is the indication. If it's hydrochlorothiazide for hypertension, obviously we want to check their blood pressure. Based on their age and conditions, what would their target blood pressure goal be? And are they meeting that? How often should we check their blood pressure? And a lot of times monitoring can vary, and you want to refer to your references. If they are on that, are they getting adequate monitoring of potassium? Probably because if they are a frail elderly resident and maybe they don't drink enough, maybe potassium should be checked at least monthly. So you want to think about the medication itself, and a good tool to evaluate monitoring parameters is once again refer to things such as long-term care, resources like Lexicomp. So like I said, what are the steps or components of monitoring? You want to identify the essential information and how it will be obtained and reported. You want to determine what's the frequency and duration of monitoring. and define the methods for communicating. And one of the things we'll do next semester when we do a lot of case examples, we will focus on particular disease states and how they relate to geriatric patients, and when is a key time to monitor, when's a key time to reevaluate. And so this should be part of the care planning. This should be part of your recommendations if you identify medication. So you want to think about when are appropriate are lab tests. And lab tests and serum concentrations, they can help identify possible risk for adverse drug reactions. Lab results, alone don't always warrant that we need to do a dose adjustment. We need to evaluate whether or not anything is necessary. The other thing is we need to look at the route of administration, and are there any issues with the patient? Do they have difficulty swallowing? Is there certain medications based on the resident that might not be appropriate due to absorption issues? For example, maybe the resident is on a proton pump inhibitor like Protonix or Prilosec, and they're also on a calcium supplement. Well, one of the calcium supplements that might be better for that resident is a calcium supplement that will get absorbed better in a basic stomach environment like calcium citrate. So you also have to look at, is the route of administration appropriate? You want to look at duplicate therapy, and obviously you kind of know the role of duplicate therapy, two or more medications from the same class. You want to look at, medications that might have combination of acetaminophen containing products, the use of multiple laxatives, the use of multiple benzodiazepines. So, for example, you have Zolpidem 5 milligrams at bedtime, or maybe you have lorazepam 0.5 milligrams at bedtime, but they're also on clonazepam 0.5 milligrams twice a day. So you want to look at, is there a necessary need for that many medications? Also, anticholinergic medications. There is a list in that table that was provided from CMS that I posted that gives you examples of anticholinergic medications. We're aware of anticholinergic medications and all the side effects that come along with that. But what we've learned in studies that it's really the risk increases the more anticholinergics we take, and that anticholinergic burden might lead to complications. And so it's always necessary that if they are on any of these duplicate therapies, that can we recommend to get rid of them, or if there is a rationale for them to be on duplicate therapy, that we evaluate what is that role and need and make sure that it's documented within the chart. The other thing is we want to look at meds for duration. So usually acute conditions like the use of cough and cold products, nausea and vomiting products like ondansetron, acute pain, and psychiatric behavioral symptoms. We want to look at when's the longest, how long should somebody be on these, when should dose reductions be recommended. Example 2 is PPIs and H2 blockers. If they're only for an acute phase, or they had been put them on the hospital to maybe for stress ulcer prophylaxis, because we know PPIs and H2 blockers have been shown to increase the risk of C. diff in nursing home residents. PPIs and H2 blockers have been known to cause effects of appropriate absorption of nutrients like B12. Sometimes facilities may have policy and procedures for stop dates like antibiotics, and so we need to evaluate always the clinical rationale for these acute meds and their duration. The other thing that's mentioned in FTAG329 is the tapering of any medication may be indicated when, for example, the resident's clinical condition has improved, the underlying causes have resolved, non-pharmacological interventions have been effective. And the goal of GDR is to evaluate the continued need of the medication and determine whether the resident is being maintained on the lowest effective dose. An example of this is in the treatment of weight loss. A lot of times you may see residents get put on, for example, Megace, megestrol acetate. And megestrol acetate may not be appropriately indicated for that resident because a lot of times that drug has only been studied to be used in cachectic patients like HIV, AIDS patients, or cancer patients. But you'll see it put on. But if you look at the evidence of that drug, if it's going to work, it's going to see help with weight gain within the first 3 months. And so what you may do is evaluate if 3 months has passed and we haven't seen significant weight gain, we want to make a recommendation of possibly a dose reduction or discontinuation of the med due to the risks of possible DVTs, especially in an immobile resident. So you want to think about, your goals of the medications they're on, and is there a time within their therapy that we could try to start doing dose reductions of that. So there's opportunities for evaluation of medication in regards to duration, obviously during your medication regimen review, obviously when a physician visits and is reviewing them. And another thing is when that quarterly MDS is, where they're evaluating the resident's conditions and state, we want to be able to do that. And so what do you evaluate when you're looking for a dose reduction? Look at target symptoms. Have they improved? Look at the change in the resident's function from quarterly evaluations. And also look at, is the resident experiencing any possible adverse consequences from that medication regimen? Now, the key ones that they do focus on specifically, and I actually gave you the document of giving the direct guidelines of this, is the following. Antipsychotics. And so what it says is the length of time before an antipsychotic dose reduction is attempted should be consistent with the condition being treated. So you have to look at it. If it's behavioral for dementia, that's a lot different than if we have a patient that has long-time schizophrenia. The frequency of the GDR should be twice a year. All right, and that GDR is clinically contraindicated if 2 previous attempts within the last year led to return of symptoms or return to previous dose was necessary because of, the benefit of using the drug far outweighed the risk. And the key thing is that has to be documented within the chart and with the physician providing that recommendation. GDR and behavioral monitoring now applies to antipsychotics according to FTAG329, no matter what the indication, behavioral symptoms related to dementia or psychiatric disorder. So even if somebody has been on it for psychoaffective disorder, schizophrenia, we should always constantly be looking at and working with other clinical staff. Can we do a dose reduction? And so, there is no exemptions anymore. At one time, that if they had a psych condition, you never looked at dose reduction. You only looked at dose reduction if it was being used for behavioral dementia. But what's recommended now is you work with psychiatry if they're being followed. You work with the physicians to see whether or not a dose reduction is warranted. And so, as I said before, within the first year after admission or initiation of an antipsychotic, there should be a gradual dose reduction attempt in 2 separate quarters within at least 1 month between attempts. And after that first year, we should try to do it at least annually. And a GDR is clinically contraindicated if their symptoms return, all right, or they worsen, and the physician has documented clinical rationale. The same thing for dose reduction is looked at with sedatives and hypnotics. So they should begin tapering after 10 days of continuous daily use. The frequency is we should try gradual dose reductions 3 times within 6 months. And if tapering is clinically contraindicated, with 3 attempts within the last 6 months led to a decline in function. The other thing, as long as the resident is on these, all right, the tapering, like I said, we should try at least, 3 times. And sedative hypnotics not only include your traditional benzodiazepines or your traditional non-benzodiazepines like zolpidem or Lunesta, but they also include agents we may use for sleep, like trazodone. We use low-dose trazodone, like 25-50 milligrams at bedtime. Sometimes you'll see hydroxyzine used for sleep, or things that we should try to avoid, but sometimes get used as diphenhydramine. Now only applies to benzodiazepines. Now, if we're looking at benzodiazepines that are not used as sedative hypnotics, like lorazepam for anxiety, those should have a gradual dose reduction after 4 months of continuous daily use. And that frequency should be twice a year. And tapering is clinically contraindicated, once again, if we tried it twice and it led to a decline. All right? And there hasn't been any mention of tapering other pharmaceutical classes that sometimes get used for anxiety, like buspirone. Sometimes you see some of our, like Lamictal, used in anxiety and behavior, or topramate. But, use your good judgment that, once again, if it falls in the unnecessary med category, we want to look at, is there any adverse consequences going on, and should we do a dose reduction? So there is a mention, though, that those agents, like I said, anticonvulsants, antidepressants, cognitive enhancers, we should always be evaluating those and whether or not a dose reduction should be attempted. And that should be looked at within maybe 2 separate quarters, and after the first year annually. So it kind of follows the same rules and regulations of antipsychotics. So once again, if you look at the table that I provided, we should be looking at antipsychotics, anti-anxiety drugs, and making sure that they're used appropriately for behavior. One of the things that happens in nursing homes, they will have target behavior sheets, and so if they are put on any of these agents, it should be documented in the chart exactly what are these agents being used for, and exactly what behaviors should we be looking at for improvement of from these medications. The other thing that says in FTAG 329 is focusing on ADRs. Any medication can cause an adverse consequence. So you want to make sure we're looking at, the clinical guidelines, the recommendations of dose and duration, determining that the resident has no known allergies to the medication, is not taking other medications that might be incompatible, drug-drug interactions, drug-disease interactions, no history of sensitivity, and we want to focus on things such as renal function, making sure that this drug is not renally dosed, and we need to make dosing guidelines based on the package insert for creatinine clearance guidelines. It doesn't specifically anymore talk about the Beers drugs, focused in general, but the Beers drugs play a big role, especially the new updated ones in 2012 and now in 2015. So use the Beers criteria as a guidance of these are medications, we probably should avoid. The nice thing about the new Beers criteria, they tell you what should definitely be avoided, what should be used in caution. And once again, there's the new article that had been published that I posted for you that talks about alternatives. And like I said, we'd be talking for hours if we went into detail of every medication, the Beers criteria. But as we provide examples, you'll see these as trends over the next cases and lectures this semester and next semester. FTAG 329 does give you that table. It lists examples of categories and possible problems. This is a guidance that surveyors use, so you want to familiarize yourself with this table and medications that go along with it and what are issues that you need to focus on. The other thing of particular relevance, the current guidelines look at daily dose recommendations, so you want to look at what are max doses recommended for geriatric patients, and you can find that documentation within the package insert within Lexicomp, giving you what are the max recommendations for geriatric patients if you click on the tab geriatric dosing or geriatric considerations. Another thing that should be considered is the appropriate the use of anticholinergic medications. This is just a list of some common anticholinergic medications, but we know that anticholinergic medications have been associated with causing things such as, constipation, digestive problems, decreased sweating, possible blood pressure issues. A lot of them are very lipophilic. They can cross the blood-brain barrier, causing delirium, confusion. And like I said, it may not be one anticholinergic that the resident is on that's a problem, but if you add 2 or 3, there's the theory of what's called anticholinergic burden. Then once we go from 2 anticholinergics or higher, these side effects become very significant, and we want to evaluate, are they necessary? Can we remove these medications? Are there other alternatives to use that have less anticholinergic properties? As I said before, in the last couple 2 years, there's been some update to the surveyors of unnecessary drugs. In fact, what I posted for you with that table is the most recent updated table, and if you can see, it's very lengthy. All right, and the regulation itself in words is not long, but the guidance table is significantly long, and that is something that they're trying to train the surveyors, because a lot of these surveyors may not always have the clinical background, but you want to make sure these surveyors look at things that are important. And so CMS has tried to give them guidance in their training because they should be looking at things such as excessive dose, excessive duration, adequate monitoring, adequate indication. Pharmaceutical services meet the needs of each resident. And so once again, if you do a good regimen review and you apply those clinical skills that you've been taught, that does every drug have an indication? You ask the questions, what do I have to evaluate for efficacy for this medication? What do I have to evaluate for adverse consequences of this medication? What are the risks of this medication in relationship to the patient's age and frailty? If you can answer those questions, you should be in good standing of addressing unnecessary medications in relationship to FTAG 329. And that's why early on this semester we talked a lot about functional problems. We talked about a lot about adverse drug reactions in relationships to elderly patients. So use those principles in guidance in looking at FTAG 329. Because here's a pop quiz. Federal regulations FTAG 329 require the residents to undergo periodic attempts at gradual dose reduction for which of these agents? Antipsychotics, sedatives, hypnotics, antidepressants. If we were all here live, I'd probably be asking, what would you pick? And that answer is all of the above. These are the key medications. And why are these the key medications? We focus on gradual dose reduction because these are key medications that have high risks that a lot of times can outweigh the benefits, and those risks can be causing confusion, risk for falls, fractures that go along with that. Okay, that can cause significant harm to the resident. So what the surveyors tried to in the recent update and guidance is that it's the guidance says within the first year on antipsychotics, the facility must attempt a gradual dose reduction in 2 separate quarters. So that kind of stayed the same. For as long as the resident remains on a sedative hypnotic, the facility should attempt to taper the medication at least quarterly. So they do realize that you should evaluate it if they're using it consistently within 10 days, but we should try to do that. And during the first year on any type of psychopharmacological medication, there should be an attempt to taper the medication at least 2 separate quarters, and after that first year, a tapering should be attempted annually. And what is a psychopharmacological medication? Any medication that's used for managing behaviors. And so, for example, antidepressants, lithium, using anticonvulsants are sometimes used in behavior, like valproic acid is used sometimes in bipolar disorder. Trazodone, low dose, is sometimes used for sleep. And so you want to make sure that your facilities, one, the resident has an appropriate indication, an active indication for that medication. If there's any lab failures or risks, for example, sertraline has been known to periodically cause SIADH, which can lead to low sodiums. Periodically check sodiums. Are we checking lithium levels, valproic acid levels? So you want to make sure besides gradual dose reduction, we're evaluating no adverse consequences are going on with this medication, specifically if we have to stay on it for a long period of time. The other thing that FTAG 329 provides guidance is there's other FTAGs that are just focused on nursing alone, and I'll give you an example. FTAG 309 focuses on quality of care, but there is some within that FTAG talks about antipsychotic use. And so if you look at if administered for discipline, convenience, or is not being used to treat a medical condition, we have to look at, are we using this antipsychotic as a chemical restraint? And so just because somebody maybe likes to roam or wander, maybe somebody just likes to talk babble, it doesn't warrant an antipsychotic. Once again, you need to ask yourself, when somebody's on an antipsychotic, are they a harm to themselves or are they a harm to somebody else? And what exactly is that target behavior that makes them a harm to themselves or to somebody else? If you can answer that question, then yes, the antipsychotic is probably appropriate. If you can't, you need to evaluate whether alternatives, and can we do a dose reduction. The FTAG 309 focuses on dementia because, as I said before, the use of these drugs, the response by dementia patients is only about 30%. So once again, if they are used, if you look down below, there should be an appropriate indication, and that nursing home usually has to use target behavioral sheets and monitor those behaviors daily. And when I want to do a dose reduction, I'll go to those behavior sheets and I'll look at them, and I use those within my notes to rationale why a gradual dose reduction should occur. I look at the nurse's notes. I look at the progress notes. Because if their behavior seems stable, then maybe we warrant a gradual dose reduction. All right. Once again, it talks about the appropriateness of monitoring. All right, and making sure we're evaluating for adverse drug reactions. And like I said before, it also focuses on, in that FTAG 309, in relationship to FTAG 329, the use of any psychopharmacological agents and making sure there's an appropriate rationale for those medications. It talks about adequate monitoring of potential adverse consequences. So some guidance is, are there any anticholinergic issues that are occurring, such as that are affecting falls or sedation? Are there any cardiovascular issues? Some of our psychoactive medications have been known to prolong the QT interval. Some of our psychoactive medications are known to cause orthostasis. Our metabolic panels being evaluated. Your atypical antipsychotics have been known to maybe increase the lipid panel. They may increase glucose intolerance, and they've been associated with weight gain. And we know that all our antipsychotics have been known to possibly cause neurological issues, such as extrapyramidal symptoms, tardive dyskinesia. And so we want to make sure that, and also risk for stroke, CVAs. So we want to make sure that there's evaluation. There's tools out there. There's what's called the AIMS tool that's used, that should be used at least quarterly to evaluate any movement disorders if they're on an antipsychotic. So you really want to refer to that specific medication and what are the appropriate monitoring parameters. And once again, does the risk versus the benefit, or does the benefit versus the risk? The other thing is, in FTAG 329, you want to make sure nursing is using care plans for non-pharmacological interventions prior to drugs. And these are the disease states they talk about that non-pharmacological interventions should be used first: dementia, pain, sleep, anorexia. Dementia can be, behavioral techniques to help the resident focus on things. I mentioned that example of getting that resident to sing. Pain is maybe, applied heat, pressure point massage. Sleep, evaluating are any medications causing insomnia. Somebody's taking high dose prednisone and they're taking it at bedtime versus early in the day. Anorexia, are there any medications causing weight loss? Can we remove? Are there any dietary things that we can change? And then the other thing is, FTAG 329 is making sure that drugs that are at high risk, frequency of drug monitoring, drugs that, like anticoagulants, checking renal function. Also, too, evaluating hospice patients and making sure that their end of life is comfortable and there's not adverse consequences going along with that. The other thing that the updated guidelines do mention is a little bit about drug regimen review. It obviously still says the same thing I taught you last week, is the pharmacist must report any irregularity, but it focuses on that the definition of irregularity in pharmaceutical services are extremely broad. And, so you want to make sure that when you are looking at irregularities, that, for example, we're going to talk about FTAG 425 in 2 weeks, but when we talk about FTAG 329 is that, medication that patient on, that there's benefit and there's no risks occurring, adverse drug reactions occurring. All right. And then the other thing it emphasizes in the recent update is that requirements apply to each resident, which we've said before, and even in residents that may only be staying for less than 30 days. If there's a change in condition, we definitely should be looking at that resident first, and that's why I gave you an example that when you go to the facility, you should always ask the nursing staff, have any residents seen any change in decline? A good way to do that is ask for the updated MDS report of that resident. If there's been any change in condition, that's a way for you to go look at it. People that are going back and forth to the hospital, these are people that are readmitted, people that have gone to the hospital and come back, and we should be looking at were there any issues relationship to drugs, such as drug-drug interactions, omissions, duplications of therapy, med-rec issues that led to the possible hospitalization of that resident. And once again, we know that we should be documenting what we're doing and making sure that the physician is accepting our notes. So the key messages to FTAG 329 is that we want to increase the responsibility of the facility, the prescribers, the consultant pharmacists, to make sure med management is being happening all the time. You should have some type of system as the consultant that the nursing staff can contact you even if you're not at the facility, if there's an issue going on. And making sure you work with the nursing staff about policies and procedures, working with a care planning team, working with the doctors about dose reductions, and also check your state regs and rules too. The state of Pennsylvania pretty much follows the CMS rules, but the ultimate goal is you have a resident that's getting good outcomes from the medications, and unnecessary medications are being avoided. So once again, this is a summary of FTAG 329. Summary of its update. I provided you a lot of material to use as guidance for you, but we will focus on next week. We will focus on that case and use that as an example as we summarize FTAG 428 and FTAG 329. Thank you for your time and have a good rest of the week.